Today's POPMA Study Club is a standardized approach to reporting of neck dissections and nodal excision for head and neck tumors. POPMA Study Club is an initiative by the Practicing Oral Pathologists and Microbiologists Association, which is known as POPMA. And under that, this is an initiative for all the oral pathologists who are either associated with an institution or in the private practice. So today we have our special guest, Dr. Nidhi Jadhav ma'am, and I would like to introduce her. Welcome, Nidhi ma'am. Dr. Nidhi Jadhav, she has finished her BDS from VS Dental College and Hospital, Bangalore in 2005 and MDS in oral pathology from Bapuji Dental College and Hospital, Davangere in 2010. She has an overall academic work experience of 14 years and is presently attached to Vasant Dada Patil Dental College and Hospital, Sangli, Maharashtra since 2019. She is running dental and oral pathology practice in Sangli, Maharashtra at Kanak Dental Clinic and Diagnostic Center for oral and maxillofacial pathologists since last 6 years. This center caters primarily to the clinical and microscopic diagnosis of all oral and maxillofacial lesions, including oral cancer. It also provides facility for exfoliative cytology, FNAC, and IHC. Dr. Nidhi ma'am has 20 national and international publications and a textbook publication to her credit. She has also presented, attended, and chaired lectures at various forums. She is also a trained tobacco control and cessation specialist certified by IDA, and she is presently a member of POPMA, IOMP, and EC member of IDA Sangli branch. So welcome, Dr. Nidhi Jadhav ma'am, and without wasting much of time, over to you, ma'am. And for today's moderator, we have Dr. Ketki Kalele ma'am. She is Vice President of POPMA, and along with that, she is co-chairperson of Oral Pathology Advocacy Unit. So I welcome you both, and over to you, ma'am.
Thank you, sir, for the introduction.
I request all the participants to keep their mic and the video on the mute mode and off mode.
Shall I start, sir? Okay, so the topic is a standardized approach to reporting of neck dissections and nodal excisions for head and neck tumors. Now, thought comes in our mind that what is the need for the topic? Before proceeding, first, I would like to have a word of gratitude to POPMA, who has given me this opportunity to present my views on this topic, share my experiences. I am very thankful to Dr. Jaideep Paul, sir, who is general pathologist attached to Mahatma Gandhi Cancer Hospital, Pradipta Patil, who is oral maxillofacial pathologist working there, and Dr. Dipti Patil, who is the head and neck oncosurgeon attached to Mahatma Gandhi Cancer Hospital in Meerut. My also sincere thanks to my BDS batchmate who is presently working as a head and neck oncosurgeon, Dr. Naveen BS in Narayana Rudralaya, Bangalore, because all of these people here have helped me in some or the other way in the making of this presentation. To begin with, the roots of this knowledge about this topic goes back to the days of my post-graduation. We were lucky in Bapuji Dental College to receive specimens of neck dissections from where the journey of learning this topic started. So I'm extremely thankful. And also in my previous institute where I got exposure to few cases further. So coming back, what's the need for this topic? Now, so we all know that cervical lymph node metastasis, whenever it is seen in a cancer patient, it decreases the survival rate by 50%. The 5-year survival rate decreases by almost 50%. So what is our duty as a pathologist is that we provide a good report, a standard pathology report with proper coordinates, proper reference points, so that the report stands as a document for the surgeon to direct the proper best treatment plan so as to avoid the recurrences that could happen in a case. This also gives a comprehensive view of the tumor categorization, that overall what is the status of the patient. So the contents of my whole presentation will be including these topics, basics on what has to be there in the requisition form, the types of the specimen, that is the dissections, including both the hard and the soft tissue that we receive, the level of the lymph nodes. Lymph nodes, how do they look when in normal and in pathological state? What are the type of neck dissections that we receive? The grossing part of these tissues, microscopy. Now, when we are reporting what all we have to see in the microscopic part, then once we have seen the slides, how do we TNM, do the TNM staging and grading of these tumors? And finally, I'll be sharing with you two report formats at the ending with conclusion. So to begin with, the TNM staging was initiated by Pyridinox in year 1952. Very basic starting of this concept. Then further in 1953, UICC came up with the first edition of TNM. Further, in 1959, AJCC, that is the American Joint Committee on Cancer, gave its first edition again on TNM. Further, in 1982, both, that is UICC, AGCC, came together to formulate the criteria of TNM in 2008. Now, presently, what is accepted and followed everywhere is the modifications of this 2008 modifications of AGCC, which was published in 2017, and it is effective since Jan 2018. Further, apart from these units, there is Royal College of Pathologists, which has given different data sets at different times, the last one being in 2021. Now, whenever we think of TNM staging, any tumor categorization, there are three things that we have to look into. The T. What is the T here? The T determines the local spread of the tumor, means how much is the size of the tumor. Like say, for example, T1 is less than 2 centimeter, T2 is something between 2 to 4, T3 is more than 4. So like there are all noted coordinates for this. N is the nodal involvement. So we are talking about the regional nodes here. N is the distant metastasis, whether this particular tumor has spread to any other part of the body, any other organ per se. Now, in 2018, ICCR, that is the International Collaboration of Cancer Reporting, has given us some core elements and the non-core elements which are supposed to be put in the report. The core elements are the ones which are definitely required. There is enough robust, intense data which has been published pertaining to the core elements which are mentioned here on this side. So these should be definitely included in your report. And the non-core elements are the recommended ones. Like if you put them in your report, it is very well and good. It will make your report more comprehensive, to be more standardized, especially if any ancillary studies are to be conducted or any research purpose, you want to use the data which was there in the reports. It is always good to put the non-core elements also. So what are the core elements? As you can see, is the specimen which is submitted, details of it, the histological tumor type, the number of the nodes that we will receive level-wise, what is this per level, then what is the maximum dimension of the nodes, then the dimension of the largest metastatic deposit. All these we are going to see in the further slides. So don't worry about extra node extensions, metastasis, and categorization of this node, with the non-core elements including what was the operation procedure which was performed, the type of the dissection, what is the location of the primary tumor site, the margin status of the tumor, that is the surgical margin related, non-lymphatic structures if they were involved, and the greatest extension of the extranodal extension with the number of the nodes. Coming to the first thing that comes to us with the specimen is the requisition form. We always expect our clinicians to give a detailed requisition form, which is a primary guide for us to begin with. So you can have these printed formats with your center name available, modified, added, okay, in which first of all, we should have the demographic details of the patient. All the details related to the medical, clinical history of the patient should be there, whatever is required, the type of the surgery that was done, what type of resection was done, the site, the nodes, the radiographic evidence, if there was any CT MRI procedure that was done prior and what has been found in that report of the patient, Any pre-operative history of chemoradiation therapies. Now, why this is important is because this will affect our grossing behavior of the tissue, also the report. And if there is a prior radiation, it also affects the T stage of the tumor. You can also have the pictures put in the requisition form where your surgeon can easily mark the sites, exactly the how he has removed out the tumor. So it will be easy for you to orient also. So these are the formats which are available. Now, talking about neck dissections, they are usually a large specimen, so they should be ideally always received sent by the surgeon in wide mouth bottle, and they should be tagged for proper orientation. Especially for the beginners, this tagging part is very, very important because it helps us orient it in the right anatomical position. Now, at times there is a double tagging system, so we should be aware that if an area is double tagged, it is an area there where there is a suspicion raised by the surgeon, and we have to thoroughly check that area. If we are lucky, we might receive, as you can see in the first picture, different nodes already bisected by the surgeon in different bottles, so it makes things easier for us. Or you might have a specimen received, like in the second picture, whole of the tissue in toto. So whatever it is, finally we have to work on it. So types of the specimens which are encountered in the oral cavity cancers, we will quickly brush through this. That first is the wide excision with marginal mandibulectomy. So as the name suggests, marginal mandibulectomy. So when it is going to be done? Whenever any tumor is in early invasive carcinoma, let's say for example involving the upper part of the alveolus only. So here these excisions are done in which the primary tumor is removed with the superficial portion of the mandible. Now, if you can see in the picture here, it will have particularly these bony margins like anterior bony margin, posterior, inferior, and teeth margin. Now, in this, there is a possibility that a coronal mandibulectomy may be done. It's basically a marginal mandibulectomy which is done for the midline anterior portion. The word used is coronal mandibulectomy. Next is the segmental mandibulectomy. The word segment indicates that the whole segment, one part, any like including the teeth, might be removed here. But when will this be done? Whenever there is a suspicion that there is radiologically the bone is involved, only then segmental mandibulectomy is done. So you get a primary tumor with full thickness of the mandible of that particular segment area. In such cases, you will have an anterior margin, a posterior margin. We should always thoroughly observe, mention the side, right side or left side. Okay, which side it is, what is the type of the resection, what is the length of this particular mandible that is received with the teeth. Coming to hemimandibulectomy, it's a big thing to do. Half the mandible is removed, so no doubt here the size of the tumor must have been higher. It would have been a high T stage, that is the increased size. So this is done. So one half of the mandible removed with the primary tumor. And in such cases, we have the anterior bony margin. Extended mandibulectomy, where the primary tumor is removed with more than half of the mandible. This is extended, means more than half. Next is the middle third mandibulectomy or anterior mandibulectomy. As you can see in the picture here, the tissues involved are related to the anterior alveolus area, floor of the mouth, lower lip region. So the primary tumor accompanies your middle portion of the anterior mandible here. And the margins that you will obtain is the two margins, which will be the lateral bony margins. Coming to the next, hemimandibulectomy with a portion of maxilla. So this is usually when the retromolar area is involved in the tumor. These are also called as retromolar trigon dissections, where you will have gingiva, buccal mucosa, related anterior tonsillar pillar areas will be obtained. And we also call it bite resections because bite in any patient is determined by the posterior teeth. So here, because upper and the lower posterior teeth are removed here, it's called as bite resection also. The next possibility is upper gingival cancers, when a part of the hard or the soft palate along with the tumor could be removed, as you can see in the next picture. Next is the soft tissues. So we saw what hard tissues we could get. Talking about the soft tissues, like tongue specimen could be a hemiglossectomy, it could be partial glossectomy, total glossectomy. So total, whenever it comes to you, it's indicative that the surgeon was suspicious of that the lesion has crossed the midline or there is a possibility of bilateral node metastasis. In such cases, we get a total glossectomy specimen. Coming to the buccal mucosal specimen, it might involve the mandible also, what we just saw in the previous slides. Lip resections, they're usually done conservative, but yes, if the tumor size is more than 1.5 centimeter, you might get a bigger specimen in this relation. Floor of the mouth resection is done, where you will get the tissues like sublingual gland, the tongue, the muscles of the floor of the mouth will be received. Now, let it be a hard tissue, let it be a soft tissue, whatever we are receiving, we have to be very keen on these findings which are put in the slides. You have to mention the tumor type. That is, what is the type of the tumor? What is the side of the tumor, the laterality, right or left, thoroughly. If it is midline, mention it like that. The size, color, the cut surface, the appearance in relation to tumor. Like, is it a ulceroproliferative grade, papillary, verrucous? So mention it in words. Note the types of the margins. You have already seen in the previous slide, different margins will be there for different specimens. Note it like that. Then distance of the tumor from the surgical margin. We will again see in the future slide what we are talking about here. Paint the margins. The deeper side of the margins specimens has to be painted. India ink, calcium glue, acrylic colors, all of these can be used for painting. They do not disturb the microscopic picture. They do not disturb usually the processing solutions also. Or easily they can be helpful for us in the orientation. Depth of the invasion, here I'm talking about macroscopically, like, with the eyes, how much depth of invasion of the tumor you are seeing. You have to measure it with the scale. See if the adjacent skin is involved. Is there any ulceration? Like, say, if it's a buccal mucosa tumor infiltrating deep through the fat, probably if the surgeon is expecting that the skin could be involved, there could be a possibility of ulcer on the skin side. Maxillary tumors, be aware whether it is having any maxillary or nasal sinus involvement. So observe your tissue specimen thoroughly for these findings. Next, coming to the level of the lymph nodes, before going directly to the levels, let's quickly brief what anatomy we have learned in first BDS, because that will help us orient our specimen rightly. So here you have the digastric muscle, anterior belly and the posterior belly, between which lies here the submandibular gland. The hyoid bone is here at this location. Then you have the cricoid bone, the tracheal part, and then the carotids. Now this red one is the internal carotid, the blue one is the external jugular vein, EGV, and this is the pink one which is running obliquely from the mastoid process up to here. The clavicular area is just sternocleidomastoid, which divides the whole neck like into the anterior triangle and a posterior triangle. You have additionally a very important thing here, the spinal accessory nerve which runs in this relationship here in this area. So let's move on to the classification. Now, according to the Academy of Otolaryngology Head and Neck Surgery, there are primarily 1 to 4. So there are other nodes also, that is involving 7 to 10. I'll be telling you about them too. But we'll detail more on 1 to 6 because these are the ones we usually receive. Level 1 is the submental node, which is between the boundaries of the anterior belly of digastric. And as you can see here in the picture, the tumors involved will be like floor of the mouth, anterior tongue, lower lip area. The submandibular gland related nodes are the preglandular, postglandular, anterior, posterior side, prevascular, postvascular in relation to the location of the facial artery. And as the location suggests, here the anterior nasal cavity, orocavity, mid-face region is going to be draining in. Then we are going to talk about level 2, 3, and 4, which are the jugular level of nerve flow. So to easily identify, keep the picture of the jugular vein in your mind. So any nodes that you are seeing in the upper 1/3 of the IJV will be the upper jugular nodes. The level 2, which is also called as the jugulodigastric. So here again, the CS of the oral cavity drain in, the nasopharyngeal areas also drain in, the parotid area drains in here. The level 2 is the supraspinal accessory, where mostly the tumors of the nasopharynx and oropharynx laryngeal area drain in. Coming to the level 3, the mid-jugular, in the middle one-third relation of the IJV, it has the sternocleidomastoid boundaries, anterior, posterior boundaries, and the oral cavity, oropharyngeal tumors drain into this side. Then next is the level 4, the lower jugular, which is also called as the Werkow's node. This is in relation to the lower one-third of the internal jugular vein, running right from the cricoid to the clavicular area. The lower one-third, level 4, that is the lower jugular. So here, usually the hypopharyngeal area, thyroid, laryngeal area is the one which is going to be draining into these nodes. Now, one important landmark to differentiate, like how do we differentiate the level of 3 and 4? So if you can mark the junction of omohyoid muscle with the sternocleidomastoid crossing over each other, that is the exact area where the level 3 nodes are separated from the level 4. And gradually, as we keep on doing specimen with experience, these things become easy. Level 5 node is the posterior triangle node. So here, even oropharyngeal area is going to drain in along with the nasopharyngeal cutaneous area of the posterior scalp and the neck. These are also categorized into two, the spinal accessory node, transverse cervical, supraclavicular node. Then level 6, very easy to remember, it's something related to the midline, anterior midline, the anterior nodes. So the pretracheal trachea is there, cricoid is there. So the nodes in relation to anterior midline area would be the level 6. As it is a midline node, so the carcinoma thyroid larynx is the one which will involve. Level 7 is the next, which is the having two categories, the retropharyngeal and the retrostyloid. So one point that I would like to tell you here is most of the times the node that we receive in relation to oral cavity tumors that has head and neck pathologist is usually 1 to 5, usually most of the time. So we need to be very thorough about up till at least the level 5 nodes. Apart from this, level 7, which is the intraparotid lymph nodes, parotid gland also has lymph nodes along with it. The buccofacial is the level 9, and the retroauricular and the occipital makes the level 10. So a lot of things told about the nodes. Let's make it simple. Level 1 is the submental, submandibular. Okay, at least related with that. Level 3, 4, level 2, 3, 4 are the jugular ones relating to the upper, mid, and the lower jugular area. Level 5 are the supraclavicular nodes. Level 6 is the central anterior central compartment nodes. Coming to the lymph node histology as in normal, and we'll then move on to the pathology side. So any lymph node, what is exactly a lymph node? Is basically an encapsulated structure. It is having a very well-defined capsule, usually oval to round in shape, and it is having a convex surface and a concave surface. From the convex surface, towards the convex surface, you have the coming in, that is the afferent lymphatic vessels coming in, and this is the concave side will be the efferent lymphatics, that is the draining side of this lymph node, external draining side. Now here, the whole of the node in cross section has two primary parts, that is the cortex and the medulla. The cortex is further having segments by these trabecular sinuses. The cortex will further have lymphoid follicles that we have read of in histology, that it has lymphoid follicles. So this is like the normal histology of the node. You can observe here in the H&E section, the cortex with the lymphoid follicles and the trabecular areas here and the medullary portion. This is how it looks in normal. But there could be a possibility of something called as lymphoid aggregate. So if you are seeing a lot of lymphocytic cells aggregated in one place and you are confused whether we should consider this as a lymph node or not. So the point of differentiation will be that it is not going to have any capsule or it is not going to have any sinus. What sinus is present here. Now in pathology, if there is tumor involvement, as you can see here, the squamous epithelial cells have infiltrated into the mass of the lymph node internally within the capsule. A case of adenocarcinoma, picture seen in the histology of the lymph node. So this was about basics of normal lymph node, how it is. Let's move on to the neck dissections. So the neck dissections that we would receive is like the radical neck dissection, MRND, which is the modified radical neck dissection, Selective neck dissection. So here there will be selection of the number of the nodes that are picked up and removed by the surgeon. Supraomohyoid neck dissection, lateral neck, posterolateral neck, central compartment neck dissection. These are four which will be included in the selective. Then there is a comprehensive bilateral neck dissection, extended radical neck dissection. Coming to the first, what is radical neck dissection? As the word suggests, radical, it is something huge. So what is happening here is it's removal of a large amount of fascia, fat, submandibular gland, the parotids, all level 1 to 5 nodes removed along with the sternocleidomastoid omohyoid muscle, the veins, that is the internal jugular vein, external jugular vein, both are removed along with the important spinal accessory nerve also. If this is involving so much of dissection, no doubt this is going to be done for a higher size tumors, that is T3, T4 level. And such resection are also called as composite commando or trials operation, commando resections or trials operation. Next is modified radical neck dissection. So what is the modification here is, uh, though level 1 to 5 nodes are going to be removed, but we are trying to preserve some of the non-lymphatic structures. What are those non-lymphatic structures? It could be the muscle, sternocleidomastoid, or the IJV, or the spinal accessory. Accordingly, there are three types mentioned. If nerve is preserved, it will be the N type of MRND. If both muscle and nerve are preserved, it will be the MN type of RND. MNV will be when all three are being trying to preserve, and it's called as functional neck dissection. Selective, as I already told you, where the extension radiographically is not so much as per the prior investigations done, so only specific nodes are removed. In this category, the supraomohyoid is when the level 1 to 3 along with fat, fascia, muscle is removed. Gland will also be accompanying this. This is something which we very commonly get in the tumors of the oral cavity. Then there are enterolateral, wherein 2 to 4 will be removed. Posterolateral, nodes 2 to 5 will be removed. Anterior central will be 6 involving. Extended radical neck dissection. So we already saw what is composite resection, that is the radical neck. Now, if in radical neck, apart from the things that were removed, the structures that were removed, if there is additional removal of any lymphatic nodes or any other non-lymphatic soft tissue structures, we'll call it extended radical neck dissection. Comprehensive, it's a very big surgery involving both radical, modified radical, selective neck, all. So in such cases, the number of the nodes received at least is at least 18, they say, per ASCO. That is at least 18 nodes we should be able to retrieve when we are doing the grossing of these specimens. Lateral neck, posterolateral neck dissections usually are coming from the ENT side most of the times, the tumors. Now, sir, can we play that videos? Bhuvan, sir?
Yes, ma'am. Yes, ma'am. I'm there only. I'll play the video.
So, I'm very
Please
thankful
stop
to,
sharing, ma'am, if possible.
yes.
Everybody can see the screen. The screen is visible, ma'am.
Yes, sir,
Yes,
visible.
sir.
Visible.
This is a facial vein.
I'm thankful to Dr.
Facial vein, and
Deepti
this is a
Patil,
facial
who
artery
has,
which comes under. This is the inferior border of the mandible, which can be appreciated here. So this is a submandibular gland, and this is a node which was palpable. It can be seen now. Looks like it is adherent to the facial artery, which has a likely to be suspicious or most very much likely to be having metastatic. On palpation, it is very hard and indurated, and intraoperatively, it is adherent to the facial artery, which gives us a surgeon a gross idea that it could be a metastatic lymph node.
there is one more video. So here, Dr. Deepti Patil, our oncosurgeon here in Mahatma Gandhi, she has tried to, show you a metastatic node, how you locate the submandibular gland. Hello? Right.
As you see, this is a vein, this is a facial vein, and this is anterior retromandibular vein, which is coming out of a submandibular gland. Sorry, parotid gland. This is submandibular gland, and this is in a facial artery. Here, we have clipped all the branches going to the submandibular gland and isolated a facial artery. You can see it is coming below the digastric.
Yes,
and it is
ma'am.
coming up on the
Sir, have you played the
face.
second one also?
That is on the
Yes,
mandible.
yes. It's
Okay,
not
no
visible.
problem. Okay, sir, no problem. We'll move if it
No,
is.
no. I have. It is already in the share mode. I'll do it again. No worries. I thought.
Sir, if you have shared, because I could not see, if it is shown, no problem, sir.
No, no, no. Just see. Can you see the screen now?
Yes.
Yes.
Okay. Perfect. So, Nidhi ma'am, can you see the screen?
Sir, I'm not able to see, but if everybody is able to see that intraoperative
I think.
videos,
What
it's
about
fine.
others?
We can see
Yes,
it.
yes, it is visible.
Okay.
Okay, sir. Okay, sir. No problem.
I'll play.
As you see, this is a vein, this is a facial vein, and this is an anterior retromandibular vein, which is coming out of a submandibular gland.
Sir, the
Sorry,
audio
parotid
is
gland.
not playing.
This is submandibular gland, and this is in a facial artery. Here, we have clipped all the branches going to
Madam
the
is here
submandibular
trying
gland
to
and
show
isolated a
like
facial artery.
how
You can
is
see it
the
is coming
what is the location of
below
the
the
facial artery,
digastric,
the
and it is
gland,
coming
the
up
parotid
on
gland. Then there is
face.
a node which
That
is
is on the
very
mandible.
closely and adherently attached to the facial artery, and which was very clearly palpable also in during the surgical procedure. So this gives you, though there are many possibilities of such videos, we have just tried to share you two of those at how a fixed node looks. Okay.
Please
Okay, sir,
continue,
we'll
ma'am. Yeah, it
continue.
was visible to everyone, and audio was also there, ma'am.
Okay,
Please
sir, I
go
could
ahead.
not hear, so no problem.
No worries, no worries. It happened. Some technical glitches. Yeah.
Okay, so we'll move to the grossing part. Now, one thing that inspires a lot as far as the grossing is related is whatever you see, you sample, and whatever you sample, you see. So it's very important that we as pathologists pick up the right things from such a big tissue that we have received so that we are able to see the right thing to give a correct report. No advanced technology can actually compensate for the shortcomings which are brought about by a compromised grossing. So the steps in grossing would be, once the tissue comes to you, first you have to orient the specimen rightly. Yes, no doubt for the beginners it is difficult. You can definitely take help of the surgeons who have and their assistants to orient the tissue. You can have some ready templates printed out and laminated with you of different areas, like you can see here the tongue area or the lateral neck area with the notes which will help you orient. Now, if orientation is difficult at times, there are some landmarks which can help you is that the sternocleidomastoid. Sternocleidomastoid muscle, which was the obliquely running muscle, is mesially placed, medial side, and the internal jugular vein is externally, like you have more of laterally placed. And also the location of the submandibular gland, which is in relation to your premolar molar areas, helps us also locate because it is very neatly, clearly seen in the as a lobulated mass in the R&D specimen. Before we start using the blades to cut different areas, we have to make sure that we take different angle photographs. As I told, if the specimen is already node-wise separated, it is going to make things easier for us. Otherwise, we have to make use of these templates. So like I wanted to try to correlate this with this, like here, this is the level 1, the level 2, the level 3, which is here the mid-jugular, level 4, and level 5. So always try to orient the neck dissection part of the specimen in this way using your template, especially in the initial days when it is difficult or you are just in the learning process. Coming to the next, after we have we've done these basic things, the next is we will look where is the growth. Where is the growth? So here in this case, the growth was in this relation. So how you have to mention, for example, these are all just representations to explain it to you. Like here, for example, if a tumor of the left buccal mucosa involving gingivobuccal sulcus, segmental mandibulectomy has been obtained along with the posterior maxilla involving the tooth to it. Now, in relation to any specimen, you will have margins. So margins, what all margins you have, what all directions of the margins you are selecting will vary depending upon the size, shape, anatomy of the specimen. Like here, if you can see, there is a medial, superior, inferior, lateral margin that is there. Along with this, you can have posterior, posterior-inferior, antero-superior, antero-inferior margins in different directions, and you can, so that these directions are going to help in taking the specimens of marginal tissues. Now, when the maxilla part was removed, here this was how it looked like. The maxillary part is removed, and here you can observe that there is a tumor. There is a peripheral grayish white area around the tumor. So this part indicates the surgical margin of the tumor, and this indicates the tumor proper area. Now, coming to here, coming to in this location, if you can observe, a part of the skin has also been removed. So in such cases, we need to mention in words that was there any ulceration or any surface changes in the skin. Coming to next, once okay. Now related to, I'm sorry, I think, is the picture seen for this slide? Hello?
This, the picture is not there.
Yes, slide is seen. Okay. So here basically what I had, I go back to the last slide to explain again. So whenever it comes to the tumor area, we have to note the location of the tumor, the extensions, the dimensions of the tumor, what is the size of the tumor. We have to note the distance of the tumor margin with the surgical margin. I've told what is the surgical margin, where exactly the surgeon has stopped, the blade has been used to separate it from the patient's tissues, remaining tissues. So that you have to measure in all the directions. The tumor extension, like say for example in the skin, is it involving the skin, the bone, or the soft tissues? Note the appearance of the tumor. Is it looking verrucous, proliferative, ulcero-indurative? All those things you have to mention. And when you are cutting this tumor part, you have to check in those sections that what is the depth of the invasion. Depth of the invasion here is in relation to the macroscopic finding. How much the tissues are altered. So it will be clearly seen as a change, like, continuing down. So measure it in all directions. And it is said that if a tumor proper is less than 4 centimeters, whole of the tumor has to be submitted and the paraffin wax blocks made out of it. And if it is a larger one, we take representative samples. Now, coming to the tumor part, like say, for example, this is the tumor proper area. You can see the margin clearance. This is the surgical margin, the proper tumor margin. We have already mentioned the distance from all the, noted the distance of these clearance margins in all the directions. Then something called as bread loafing, what Sharda ma'am also had presented in day before's lecture about grossing. It was a very nice lecture. So bread loafing pattern, you have to like take different sections at 5 to 10 millimeter of the tumor proper area. Okay. Then this will also help you know that, what is the depth of invasion in the tumor, which I could not show you in the last picture, in the last slide. Then coming to the surgical margin sampling, now we have taken bits from the tumor, we have taken the sections from the tumor. Now what we have to do is we have to take the radial margins, like here, these margins we have to take. So here 5 tags which have been put are like the 5 representative margin areas where the sample has to be removed. We have to sample with the blade and make sure you always ink the deeper side of this. Why? Because once we directly put it in the cassette, and later on it will be difficult for us to orient it in the right way. We should be able to correlate when we are seeing in the microscope, like, which part is having tumor tissue, which is not. which we will understand more better in the coming up slide. There is a picture related to the inking. So here, this deeper side is inked. If you have to take any bone related specimen related to the margin, we usually take a shave margin using a bone saw, or you can also use a disc. Now, this is what I was telling you about. You can use Alcyon India ink, or the acrylic colors are also used. There is definite color coding for the margin superior should be done in different anterior mesial. There are color codings which try to avoid confusion for us later on, and we should not never mix them. So here it helps us in the orientation that this is the side towards the tumor and this is the side towards the surgical margin when we are observing in the microscope. A little bit more on the radial margin. What is it? It's basically the circumferential margin as to how much of the normal tissue was removed around the tumor. Okay, it helps us know the margin clearance. If this is more than 5 millimeter, we consider it as adequate. If it is 1 to 5, we will consider it as a close margin. And if in any area, suppose it is very less, like as you can see here, almost touching the surgical margin, the tumor is touching the surgical margin, these usually come on microscopy as positive areas. So they will be marked as positive. Importance of this margin is that if any margin is positive, this tumor is having a high chance of recurrence, and it is later going to be, the patient is going to undergo adjuvant chemoradiation therapy for the same. Now, ideally, as we have seen in the previous pictures, if we receive in different containers, different levels of the nodes, well and good, it will be very helpful. But if not, then we have to dissect in that whole big specimen. So you have to separate at level 1 to 5 nodes. Here, there is a video about how we can remove the nodes. I'm thankful to Dr. Pradipta. I had taken the video of this grossing to show here in the presentation. So as you can see, this is the specimen, and here these are the nodes removed. So if you can observe, he is trying to palpate with the finger the round nodular swellings. Sir, is the video seen? Hello?
Yes, yes, ma'am.
Yes.
Is the video? Okay.
Yes, ma'am.
So she is trying to
Yes, ma'am.
palpate with the tissue with the fingers and removing the nodes one at a time, and the remaining tissue is here then put aside. So overall, the number of the nodes are being noted down. We have to see what is the largest size of the node, note it down, and if there is any presence of metastasis in, like here, I'm talking about again macroscopic view. We have not moved to the microscopic. So here, if you can see, there is a break in the capsule. This normally a lymph node looks brown in cross section, but here, as you can see, glistening white appearance, which is indicative of the tumor tissue. It's a metastatic node. Whenever we are removing the nodes, we have to make sure that we should not miss out any node which is larger than 3 millimeter. So this process takes time. You have to remove also the perinodal fatty tissue over the nodes, and then section them at least in 2 parts and then put in the capsules for better fixation. Once the nodes are removed, separate like this level wise so that accordingly we can further code and number them. Level wise also we have an idea of which node were, which was the level which was having like the largest node. Okay. Then coming to sentinel node, this is the node which is the first and the primarily affected node as per the tumor location. Say for example, it's a tumor of the lower lip. So the submental is something which could be possibly more commonly involved. So sentinel node biopsies, though there is a lot of controversial literature about their studies, but still because it is something that comes in the dissection parts, we should know about it. This is traced with the isosulfan dye. It's a radioactive dye. So if you are receiving a sentinel node biopsy, these are usually, in such cases, 2 to 3 nodes are removed. 3 is the like upper limit for sentinel node biopsy. So these, whenever obtained, you should totally section them and keep some sample aside for IHC investigations if you need. Coming to the node part, again, at times you might in grossing observe this appearance, which is called the matting of the lymph node. Many lymph nodes are attached to each other here, how we see in the like tuberculosis. Here, these are two nodes attached to each other. So in such cases, you don't have to measure individual nodes. You have to measure the whole full thickness of this matted appearance and determine its dimension. And you have to take sections at 2 mm distance for these nodes, because it's very important, because these nodes usually come out as positive nodes microscopically, and this affects the survival rate also. The more the nodes which are matted, the lesser is the survival rate. Now, this is a macroscopic dictation template. All the things that we saw in the macroscopy till now, we should try to record in such a format. We can, again, as I told you, detail it more as per our requirement. So what tissue was obtained, the procedure, the laterality, the specimen dimensions, any other soft tissues that were received along with the nodes. Everything, the nodes, the size, the maximum metastatic deposit, all this has to be mentioned here. And you also have to mention that in a margin, which is the margin which is the closest to the tumor margin, which surgical margin looks to you as the closest to the tumor margin. Just make a note of it before proceeding. Now, all well said and done here. Like I have put it here in words, like in your grossing details, you should have at least such type of description. Like say, in relation to this specimen, the left mandibulectomy with excision, posterior gingivobuccal sulcus along with tooth. Now here I have mentioned a size in relation to the upper part. This is the size in relation to the upper part. Skin, if there was any evidence of ulceration over the skin, what was the color, consistencies of the tissue. Then coming to the tumor proper description, now here we are again describing the tumor, how it was, what was the size of the tumor, and making different codes for the tumor proper. How many bits you have selected from the tumor proper area, those vertical slices that we saw in the last slides. Then you are taking those radial margin specimens, the anterior, posterior margin. You are also mentioning how much distance was there from the tumor, and the bits, that how many bits you are going to put in the capsule for each margin, and label them accordingly. As far as the hard tissue is concerned, you have to do decalcification to find out if it is involved or not. Always measure the anterior portion, the posterior portion also, and give different numbers to it also. Coming to the lower part, this is the node part. We have already learned how we have to remove the nodes. Level wise, we have separated the nodes. So we'll total them. What is the total number, which is the largest size of the node? Microscopically, what we saw, that extracapsular spread was there. So if it is present or not, just mention it. At least this much should be there in the crossing. So next, we move on to the microscopy. Our slides are ready, processing is done, slides are ready according to the proper number-wise format. So first, we will look into the tumor proper slides. That is like how A1 to A4 for like in the last specimen. So tumor proper slides, in that 3 important points you always have to note down. That is, what is the type of the tumor? Like here the picture, it looks like of oral squamous cell carcinoma. So you also have to mention the subtype, because that affects the prognosis, because varicopapillary have a good prognosis, spindles have bad prognosis. So you should mention the type and the subtype. What is the pattern of the invasive front? It's coming up in the next slide. And the depth of invasion. These 3 parameters are very, very important in the tumor proper part. Now, pattern of invasive front. What we have to do here is, we have to go look at the tumor stroma interface, where the epithelial infiltration area is, coming in contact with the connective tissue part, and observe what is the pattern of the invasion. So accordingly, there are 5 which have been given, type 1 to 5. The first picture shows the type 1, the pushing border type pattern, which like something looking like how you see in the verrucous carcinomas, broad white ready ridges. Type 2, the finger-like growth extending downwards is the type 2. Cohesive, when the number of the cells in these individual islands is usually more than 15 cells. Then the type 4 is when the number of the cells is less than 15. So as you observe, when you go from 1 to 5, the number of the cells in each of these islands, the tumor satellites, is decreasing. The last is the type 5, the worst pattern of invasion, WPOI, which is when the tumor satellites are at least at a distance of 1 millimeter from the main tumor bulk area. Like, this is the main tumor bulk area, and at a distance of 1 millimeter or more than that, you are observing some tumor foci, you will include it in the straight away in the type 5. And These are the ones which are usually associated with perinural and lymphovascular invasion because the nerve and the vessels are located in the deeper side of the connective tissue. Coming to the third we are speaking about is that is the depth of the invasion. So for depth of invasion, first locate an area away from the tumor area, go towards the side of the normal epithelial connective tissue junction, locate the basement membrane, and from this basement membrane area, then you have to record that what is the distance of the basement membrane to the deepest point of the tumor tissue. So this is the depth of invasion. Now the question comes in mind, different areas, it might be undulating basement membrane according to tumor presentations. So you have to take an average of 2-3 areas and then take a value if this is happening. And the next thing is tumor thickness. This is different from the depth of invasion. What is tumor thickness? Here we are taking the relationship right from the topmost layer of the epithelium till the deepest point of invasion of the tumor cells. Both these parameters are measured in millimeters. See, if we do not have all these softwares that I have mentioned here, at least, though not so precisely, but we can make use of the scales which are there on our slide platform, and at least approximate values we can give after measuring starting the coordinate and where you are ending. So give it in millimeters approximately, though if not precise. Otherwise, softwares can be definitely used for obtaining this. Now, according to AJCC criteria, when we are reporting the tumors, the new addition that has been done is that the depth of invasion is now included in the T category. Again, let me tell you what is the T category. It's about the size of the tumor, 2 to 4 or less than 2 centimeter or more than 6 centimeter, like depending on the size the T is there. And DOI is added to the T side for the TNM staging. So we have to remember this point because this depth of invasion actually determines the aggressiveness and invasiveness of the tumor. TT is a bit confusing because it can overvalue or undervalue your tumor invasiveness because the reason being that you are it might be an exophytic growth or an endophytic growth. So in exophytic growth, the TT value will be increased. Coming to the margins, we have already taken the margins from different areas, those 5 points. If you remember through this picture, we have noted down, given the numbers. And if you are seeing those slides and you find tumor tissue in those, then you are going to consider it positive. If you find high grade of dysplasia also in any of the slides, you are going to consider it positive, high grade dysplasia again. And if it is a close involved margin, no doubt, the patient is going to later go on for the chemoradiation therapy. Now, this 3 points were related to the tumor proper slides. Now we are going to examine the nodal slides, the node related slides. So what all you have to observe? First thing is observe that if the slide is having, the lymph node is having nodal metastasis. So we know how the normal lymph node looks like. So observe the changes here that there is infiltration of the tumor tissue here. The tumor tissue has already metastasized to the intranodal keratin debris. Usually, when the squamous epithelial cells, we get to see such squamous keratin cells might, keratin debris which is coming up from the squamous cells. Areas of necrosis, if there should be noted down. Any cystic changes, if you are observing, you should note it down in the lymph node. Then one point we have to remember is that metastatic deposits. Like if we compare the tumor proper with the nodes, in the nodes, the tumor that you would see usually most of the times is less differentiated. What I mean to say is, if you are seeing in the tumor proper and you see most of the picture looking like well differentiated, there is very much possibility in the nodal side, we might see picture looking like more of moderately differentiated, but the diagnosis is going to be based finally on the tumor proper area. Then coming to a single node, if there are multiple involvements of metastatic foci are there in a single node, you always have to measure the largest metastatic foci. Okay, like here in this slide, this is the dimension of the largest metastatic deposit because again, this is a determinant in the further coming up TNM staging. Coming to the size of the metastasis. Now here we have something called as micromets, or we hear it like micromets or micrometastasis. So what is it exactly? when the size histologically is less than 3 millimeter, it usually does not say, change the overall size of the lymph node. And when it is more than 3 millimeter, but when it is less than 3 millimeter, we call it uh, micrometastasis. And we have to tag those particular nodes as in bracket MI, that you could see a micrometastasis event in those particular node levels. So always mention it. There is something called as isolated tumor cells. Now we are leaving the node aside. If apart from the node, in the perinodal connective tissue, anywhere in the soft tissue areas, if you are seeing tumor cells, those will be called as isolated tumor cells. And when they are less than 0.2 millimeter, or so to say less than 200 cell dimension, less than that value volume, we will call it isolated tumor cells. Next parameter is extracapsular spread, which is basically here that how much beyond the level of the capsule, this is the normal without, and how much beyond the capsule the tumor foci have further progressed. So this is again two varieties, a micro extension when it is less than 2 millimeter, a macro extension when it is more than 2 millimeter. The higher this extension, the worse is the prognosis of the case. So as I told you, extracapsular invasions, these are relating with the survival rate. Many a times you will see less survival, recurrence, or distant metastasis when you see an evidence of ECS, that is extracapsular spread or extracapsular invasion. Coming to the soft tissue metastasis is when, like here, this is the body of the lymph node, but away from it at a long distance, somewhere near and around the blood vessel, you are seeing these small foci of the metastasis tumor tissue, which is called as the soft tissue metastasis. And these, when related with any vein, like as a emboli, again, the prognosis is going to be bad. You have to make a note if you are observing any intra-lymphatic or intravascular emboli or tumor tissue within these vessels. We have already seen node related. We have to mention the number of the nodes, the site which is there, how many nodes you have observed, because all this will be relating with the prognosis, and also very important to mention it. As far as the size is concerned, it directly does not correlate with prognosis, because why I mean to say it, at times a reactive node also might be quite large in size. So what is important, if microscopically we are able to see the evidence of the tumor tissue. Stromal reaction, this is in relation to not the tumor cells, but in relation to the stroma. So the first picture shows that if you can observe, there are a lot of fibroblast cells, collagen matrix formation, which is there. So when you observe such findings, it has been found as per studies that there is 7-fold risk of recurrence in such cases. In contrast to what you see on the right side, wherein the lymphocytic infiltrate is more than the stromal reaction. So if you find such situation, it is having a graver prognosis. Other things, the intralymphatic emboli has to be noted down. The more the tumor differentiation, like well differentiate, will be having better prognosis than the moderate. So recurrence. Last part about the histology before we move on to the TNM staging is irradiated neck dissection. So it's not necessary that always the surgery is going to be done first. Maybe if the size of the tumor is large, surgeon wants to come to a situation where it becomes operable, smaller in size, a prior chemoradiation is given. So in such cases, when you are dissecting those specimens, they will be quite fibrous tissues. Probably the number of the nodes that you will receive will also be less. You might also see histologically abnormal nuclear types like micronuclei, double nuclei, budding, all those things. Hyperkeratinization or keratin granuloma, all these might be seen. Even you can see the giant cells, as you can see in the right side slide, that there are giant cells, multinucleated giant cells. So all these things that we learned till now, I'm going to brief in 3 slides. The type of the resection has to be mentioned, the dimension of the tumor. You have to mention the incisional report, excisional report, grade of the tumor, and always if there is a mixed variety, you have to always take a higher grade when reporting. Invasive front, margin status, positive or negative, depth of invasion, one thing very important, as the depth of invasion, microscopic depth of invasion increases by every 5 millimeter. If you can see here, the T level increases considerably. So this is very important parameter which has been added up in 2017 AJCC. Perineural invasion, any tumor which is at least involving 1/3 of the nerve circumference will be considered as positive for perineural invasion. The tumor cells might be in the nerve sheath also. In such cases, the radiotherapy becomes the must. Now, what we have to remember, the intratumoral and extratumoral. What is extratumoral nerve invasion is when away from the main tumor site, somewhere deeper here in the nerve area, if you are seeing a perineural invasion, in such cases, the prognosis is worst and you have to mention it. Lymphovascular invasion, we have already seen that has to be mentioned within the lumini or proliferating through the wall into the outer soft tissue. If skin is involved, you have to mention it in words because in such cases, radiotherapy is again needed. Now we will look into the TNM staging. Now we have seen so many things. What is a normal lymph node histology, the dissections type, the Brossing events, then what all we have to see in the slides and microscopy. Now we have some of all this data in our hand. We have written somewhere in the rough all these findings. Now the time is that we move on to staging the tumor. Now most of the times, postgraduates especially, we must have heard of TTNM, right? So apart from this, there is something called as CTNM, YTNM, and RTNM also. So what is CTNM? When the patient has come to the first time, come to the surgeon, and radiography has been done, CT MRI has been done, and the grading which is determined at this level without any intervention is the CTNM grading. Then YTNM, that the neoadjuvant chemoradiation therapy has started, patient has yet not gone for surgery, and there is some time before that the surgery will be done and the grading is done subsequently. That is called as the TNM, YTNM grading and staging. And the third is what we usually do as pathologists after we receive the surgical resection specimen is the PTNM. And if the patient is coming after a recurrence and the tumor is re-excised, the second surgery of recurrence, and you are reporting the case would be the staging would be the graded as RTNM. So these small letters, initial letters have to be put in your report. Again, a short revision in AJCC 8th edition, the depth of invasion has been incorporated in the tumor size and extranodal extension has been included, except for the T16, that is the HPV16 positive oropharyngeal cancer and nasopharyngeal cancer, which have a different staging protocol. The TNM staging we should know is applied for all the epithelial cancers of the head and neck, like squamous cell carcinoma. Some exclusions, notable exclusions of head and neck are like, as I told you, HPV-related oropharyngeal cancer has a different data set. Nasopharyngeal carcinomas, mucosal melanomas has a different one, which at least as the HPV part I will show you. Non-odontogenic bone, soft tissue, lymphomas, they again have a different data sets. Now, question comes in our mind, what about the odontogenic tumors? There are so many odontogenic, we as dentists will come across the odontogenic tumors also, though relatively rare, but yes, what about them? So the TNM staging has not been systematically formulated for them. We should know that. The reason being, now different tumors have a very different tendency of their clinical features that they show, and like the way they are treated also is very different, and also that each and every tumor has a very different way of showing its recurrence pattern. So that is the reason the studies in relation to them are less. So TNM staging is not differently done for odontogenic tumors. Now comparing quickly the 7th and the 8th, like what we read in our post-graduation days, that time we started from TX to T4 depending upon the tumor size. Now there is no more TX, T0, it starts from T1 to T3. And if you can observe, this is the clinical tumor size, clinical radiological size, and depth of invasion is also included. See, we cannot always mug this TNM staging chart. It is always good to have a printout ready for use. You already have a rough data written for about your slides, what you saw. So compare, see where your tumor fits into, and then decide the T stage. The T4A, T4B are the cases where the case is moderately advanced local disease, very advanced local disease, depending upon the extent of the tissues which are involved. Now, in relation to T4A, there is an exception made for tongue because if there is metastasis in relation to the tongue muscles also, it is not directly considered under T4A. We have to remember this exception. Coming to the end part, so as you can see, the previous 7th and the 8th, so here extranodal extension has been included, which was previously not included. Previous 2008 was just including the size of the node, but here the extranodal extension has also been noted. So see, observe where the node status of your tumor that you are going to stage comes in, thoroughly observe again and again, and then give the staging. Midline nodes are always considered ipsilateral, depending upon the tumor position. Then coming to the M part, so for every case, PET scan is not done. So the M part will be noted down when the prior PET scan was done and you have an evidence of whether the metastasis was present or not. Like if it is having no evidence of metastasis, you stage it as CM0. If there is metastasis, radiographically, you stage it as CM1. And if you have confirmed microscopically also, like you say, if the metastasis has is to the liver or lungs and a biopsy is taken from there and you have seen SCC components seen there also, you will consider it as a PM1 stage. So depending on what T we got, N we got, M we got, we are going to do the stage grouping here. So here the grades that we call like 1, 2, 3, 4A, 4B, 4C, depending upon where your tumor fits in, you have to thoroughly do it. Now coming to a point about the oropharyngeal carcinomas, like we might have oral squamous cell carcinomas which are HPV positive or negative, which will be identified. Ideally for every case, it should be done with IHC or PCR. But so as far as the theory part is concerned, we should be aware that for these HPV positive cancers, there is a different T and N staging protocol. Here, there is no depth of invasion included, and here there is no extravascular extension included. It is just they bother about the positive or the negative number of the lymph nodes. And coming to again here, their grading stage is also different accordingly. Here, salivary gland malignancies, I would like to mention quite similar protocol, but just that here, whether there is extra parenchymal extension or not, we have those points added up. So when you are preparing a case of salivary gland malignancy, this is the table that you have to refer to. Now, before I finish, I will like to show you two formats. Sir, should I directly go to that?
No, you have to, ma'am, stop sharing and then you can share that PDF you want to show, no?
Okay. Is it seen to everybody?
No, ma'am.
Is it?
It is the same way, ma'am, how you share your...
Yes, sir. Is it seen now?
Yes.
Is it seen? Yes. Okay. So all the things points are again, it's you can follow a printed format like this. This is the format which has given by the ICCR, available on the net. I'm going to forward also these things in our group later on. So we'll quickly see through it. So the demographic details have to be mentioned, receival number of the case, accession date, all those things. Previous therapy, the reason I told you we need to know about the previous therapy details because it affects our grossing and the findings related. What procedure was taken up? What type of neck dissection procedure it was? You have to see what are the nodes that have been submitted, like left side node, there is a separate section. There is a different section for the right side. So all different levels of the lymph nodes have been mentioned here. Any non-lymphoid tissue, like say gland or muscle or vein that you received, you have to pick them accordingly here. Then some central compartment nodes, there is a separate section. Now we have to keep ticking accordingly or mentioning in words. Then coming to the histological tumor type, for say example, if it was a squamous cell carcinoma conventional ticket, lot of options have been given here in this format. Okay, so keep salivary gland carcinomas are there. Then there are grades. What grade you feel that the tumor comes into? Is it a well differentiated, moderately? Take it accordingly. And margin status. So you have already made blocks separate, which are positive, which are negative. Mention that here. Ancillary studies is about like if you want to go for any IHC or HPV testing for any of the tissues, has to be mentioned here. Then lymph node status, like the same chart will be for the left and the right side. What are the number of the nodes examined? What is the number of the positive node, or if there was any extra nodal extension less than. So everything that we saw in the PowerPoint is there here in this format. Then maximum dimension of the largest node that was seen, if it was seen on the left side. Then any non-lymphatic structures, if this that was involved. So the same protocol will be followed for the right side lymph node. So I'm moving forward. So the lymph node status. Then here they have given a reference table for the TNM, what we already saw in the last few slides. The TNM, right? So you can follow them depending upon which tumor you think has come to you. Now this is a tabular format, easy to follow, quick to do, you know, don't have to do so much of typing. But there is, but I feel every pathologist has different opinion for that matter. What I feel that there should be a detailed descriptive format. So I have actually gone through the R&D reports of at least 3 to 4 centers. I have tried to make a sample format, just consider it as an imaginary tumor coming up here. Okay, and how we are going to report it. Again, the choice varies whether this pattern or that pattern. So here see, as per the modifications of AGCC 8th edition, so that we do not miss out anything. Here are your demographic details of the patient, everything related to his data entry, register number, and everything. Then the case number, histopathology that you are going to give. Okay. Then the clinical details that have come on the requisition form, like say, for example, here I've considered that this is a non-healing ulcer over the right buccal mucosa since 4 months, and the growth is so much that it is involving the retromolar trigon right from the commissure area to the retromolar trigon involving the gingivobuccal sulcus. All those, that's the extension of the tumor. And the clinical diagnosis that was given by the surgeon is OSCC. Incisional was done, which was OSCC. So just an imaginary case, okay, just to show you the protocol, how it can be done. Now, this is the specimen detail that we are receiving from the surgeon in our requisition form. So say, for example, the main specimen, I'm talking about the tumor proper. So if the tumor has been tagged, exactly mention where all those tags have been, they have come and exactly which side they have come from. Like say, for example, there were 2 long taggings in the posterior mucosal margin, 2 short in the anterior mucosal margin. So like this, you have to note down of the specimen. Now there is a particular number which is continuing, which has come from the surgeon. We are not going to change this till the end. Right level 1 nodes, left level 1 to 5 some, there is a here the nodes of the left side have also been included. Left level 1 has come, left level 2 has come, though the tumor was on the right side. So just keep a note, further we will make use of it. And till 13 number you have the nodes. Then additional parotid tissue, additional anterior superior soft tissue or anterior inferior soft tissue margin, maxillary sinus. So these were the additional tissues which were obtained apart from the tumor proper and the nodal area specimen. Now we start with our gross examination. So as I mentioned to you, you have to divide your specimen into 2 parts, the tumor proper part and the lower part of the neck area. Measure its sizes, measure from where all it was extending, write the measurements here, and measure, also write in description what were the different values of the tumor margin from the surgical margin. So this description is about like anterior distance of the tumor margin from the surgical margin, posterior. So all those in centimeters you have to mention. I have also made a note to the point that you have to mention about which margin was the closest to the surgical margin. Now we have sliced the tumor. Now we are seeing what it looks like, grayish necrotic white tumor extending into the subcutaneous tissue. and what is the distance from the different inked margins, that all you mentioned here in the after you have sliced it. If there was a salivary gland obtained here, what was the size of the gland? And if you are able to retrieve any nodes in relation to the gland, what was the size? Everything you mentioned. Now we are starting with the bar coding according to like how we will be putting in the slides. So here the blue ones I have purposely coded, color coded, so that it becomes easier for you to understand that within lesser time during the presentation. So everything from A1 to A5 will be the mucosal margins related to the surgical margins. Okay, so here we have taken, so these positive or negative, this is going to be very important if they are positive or negative. The margin, surgical margin status in relation to the tumor. Then the skin side was also removed in this. So the anterior skin soft tissue margin, posterior skin soft tissue margin, these are different margins. I'm not talking about the mucosal side margin here. So the buccal side, the cheek side. Then inferior soft tissue with salivary gland was obtained. You can additionally take tissues from different areas, like here temporalis area, because this is tumor involving this whole area. So if we are getting a temporalis measure, let us take a sample from that area also to know if there is any extension that side towards the scalp side. The posterior maxillary pterygoid plate area, you can take a sample from that side, looking at the size of the tumor, big size. And now the slides of the tumor proper, mention the number, what are your tumor proper slides, how many sections you are taking from the tumor proper, those vertical bread looping sections or that you have taken, salivary gland, then the lymph nodes, the margins, then bony margins. Now we need to do decalcification. So accordingly, whichever side you have taken, you mention the side, laterality and everything, and give particular numbers. Now let us come back to this number 2. So if you can relate, this number 2 is according to the surgical, what we saw there. So we are proceeding in the levels, seeing the number of the nodes in each level, what is the largest size, what are the blocks that we are fitting them into, everything we are noting them till the question, till number 13. So this is what, according to the reference that you obtained from the surgeon. Then the parotid tissue, we are again making its size mention, block mention, and maxillary sinus. Now coming to the reporting microscopic examination part, what is the focality? Is it a unifocal tumor or two tumors at the same time, nearby location? Location, site, laterality, the size, the type of the tumors, the subtype of the tumor, the grade of the tumor has to be mentioned, the depth of invasion that we noted down. This is the macroscopic depth of invasion as of now here, because it's in centimeters. Lymphovascular invasion, worst pattern of invasion, all this we have identified. Tumor extent we have to give in detail. Then specimen margins, closest mucosal margin we have to mention in relation to the tumor, and the parotid tissue, all those findings. Now coming to the lymph node status, if any lymph node is positive, regional lymph node status, mention about that it is having metastatic carcinoma, extranodal extension. So here if you observe, in this case, there are level 1 nodes of the right and two nodes which are involved here. So finally we come to the pathological staging, that is PTNM. We can refer back to the table and see where the tumor fits. Like here, it's finally we are giving an impression of a moderately differentiated carcinoma extending from the right buccal mucosa, extending into the masticator space. Extranodal extension is also there. Bone margins are involved. So depending upon how it is, finally we are giving the staging of this case. You can involve the M part if, as I told you, if the PET scan is done, you can involve the M part also, depending M0, M1, like that you can involve. So this is how I wanted to like show you a sample report. With this, I come to the conclusion of the uh, presentation. Yes. 1 minute, sir. So So to conclude, I would say post-operative chemoradiation is a very toxic treatment that patients have to undergo after surgeries at times. So we as pathologists, we should be very thorough in giving a very comprehensive reports to our surgeons so that the rightly directed treatment is planned by the surgeons. With this, I would like to conclude and thank you all for your patient listening.
Yes, really very comprehensive and extremely important topic. That too, ma'am, your hard work and everything was getting reflected a lot in, assembling all the material, the latest guidelines, the videos, everything. So absolutely wonderful job on that, ma'am. Thank you so much for all your efforts.
Thank you.
Yeah, we have certain questions. Actually, there are many compliments for you too, ma'am, in the chat box. And along with that, we have certain questions like Buddha Harika Varshita have asked that, ma'am, can you explain skip metastasis and its difference from sentinel lymph nodes?
Uh, Sentinel lymph nodes is when, depending upon where the tumor location is, the probability of the first site of, first level that would be involved depending upon the type of the location. Like, for example, if it is a tumor is in the gingivobuccal sulcus in relation to your lower premolar molar area, probably the submandibular level 1, level 2 might be involved. Okay, so those will be the sentinel nodes. Then we talk about, say, posterior scalp related area. So the lateral triangle area is the one which those nodes could be primarily involved. So that becomes the sentinel node depending upon which site of the tumor we are talking about. Now, there is something called as skip metastasis, wherein the tumor is actually skipping the nodes which are there in between. The tumor is actually skipping the node which is, hello?
Yes,
Am I
yes, you're
audible?
audible. Yeah,
So
you're.
it is so the tumor in between is being skipped and the
I think we have lost connection with ma'am.
Okay. Can I add something here?
Yeah, please, sir. Please
Yeah.
go ahead.
Sentinel is probably the first lymph node where the area drains to. So positivity is checked during these. Sometimes when they do biopsy, sometimes they also think of doing the sentinel immediately in the OT in this frozen sections. They tend to do the sentinel nodes also sometimes. And skip, as ma'am was telling, it goes from 1A to is 1A. It usually goes and drains over there. That is not positive. Else, another level is positive. So
yes,
that's what is skip metastasis.
it matters.
So it does indicate poor prognosis sometimes.
Yes. Nidhi ma'am, will you like to add something on what Abhishek sir just said regarding skip metastasis?
Uh, and as Dr. Abhishek told rightly that when there is the in between nodes are, usually the nodes drain from 1 to 2, 2 to 3, 4. So rather than being the first possible node being involved, the tumor directly through the emboli is getting transmitted to the next level of the node. That would be the skip metastasis.
Yeah. Any more questions do we have?
Yeah,
From
I would like to ask
Yeah.
a question. Ma'am, I must tell that kudos to you. You have done really justice and covered all the aspects of AJCC 8th edition. What should I say? I have few questions. Like, what common pitfalls you have faced in reporting neck dissection, and what recommendations you will say to avoid such pitfalls while reporting?
Yes, and then sir, I would like to ask my pitfalls that how should I do it?
and
Nidhi
and
ma'am.
sometimes we face borderline findings also in nodal metastasis. So,
Uh,
how you communicate in your reports?
Sir, what I consider that tumor margin status is very important. So there, if any thing is compromised in the grossing part, that is going to be very significant. And obviously, if we are while grossing, if we happen to miss out picking up any node, because it's actually a very extensive procedure. If you thoroughly do it, it takes the grossing itself takes 2 to 2.5 hours. If you are doing a thorough, sincere grossing, so it takes a lot of patience to really feel those node in that big tissue, remove it, remove the adipose tissue, see it thoroughly. Okay, that is one thing. So we should not be able to, we should not be skipping those nodes as much as possible. Another one thing always comes in my mind personally is that what about the remaining soft tissue? Every setup is not having that level of facility that we make hundreds and 200s of slides for the whole tissue. Okay, so soft tissue metastasis, I'm talking about like muscles, deeper part of the fibroadipose tissue, all those things. So we don't actually really look into those areas. We grossly first do the tumor part as per the protocol. We select the nodes, see them. Perinodal tissue, yes, we observe because by default we are removing the nodes, so perinodal tissue comes along with it. But there is a lot of, actually 80% of the tumor bulk is still remaining behind. And every institute is not fully grossing it and submitting it for the slides further. So this one pitfall is there until we really thoroughly do as much as number of slides. And other thing that in the lymph nodes, again, because of limitations, we might take 2, 3, 4 section per node, but literature says that every 2, 3 millimeter we have to take a section. If suppose it's a node of like say 2 centimeters, so imagine how many sections we are going to get in that single node. So many nodes, 30, 20, 40, 45, and like just justice to any one or two which are large is a pitfall in itself.
Correct.
Yeah, moreover, ma'am, I would like to ask, what about the shrinkage-based marginal assessment? Because
Yes.
that is the routine thing that cross my mind every time I am confused between a close and an involved margin, personally. That
Uh,
should shrinkage be there in our mind, and how do we actually deliver the reports then?
Ma'am, as much as of what I read, yes, no doubt, when the surgeon is excising, there is a lot of stress tension that happens on the tissue in that area. And after that, once it is put in the formalin, there is shrinkage. So as of what I read in relation to your grossing part is like the margins in relation to the grossing. So I think we'll consider those margins. And more than the size, let it be less than 5 millimeter also. But most important is, are we finding any tumor foci histologically? That is, I feel.
Ma'am, your voice, you're muted, ma'am. Please unmute.
Oh, am I audible?
Yeah,
Yes.
yeah. Yes, you're
Sorry.
audible.
So here in that case, what is important is that we, see properly margin wise whether microscopically they are involved or not. It's not so much that, by theory they say 5, more than 5, less than 5, equal to 5. So more than that, here it's important that we see a microscopic evidence of tumor in that area. And what I saw in the literature was as per the grossing findings, these 5 and 5, I think the surgeons usually take it a higher level. When we are
Yes.
finding it 5 centimeter, 5 millimeter, so I am sure the surgeons are taking at least 6 to 7 or 1 centimeter also. Because
Yeah,
after
but ma'am, that is,
shrinkage, we see.
yeah, that is, ma'am, every time it's not possible for them, especially when it comes to the lateral, sorry, the ventral portion of the tongue, the base and
Yes,
of the tongue and all. So there it becomes tricky, where the anatomical barriers are
there,
such.
there, no doubts. No doubt.
Yeah, yeah. So I think that is again a major
And
pitfall.
Yes,
and
yes,
ma'am,
ma'am.
apart from PAN, CK, P40, and CD45, do you use any other IHC marker for ambiguous lymph node metastasis.
CD31 they say is helpful.
Okay.
CD31.
Because PAN-CK and CD45 helps in lymphoma and the epithelial origin, majorly the squamous cell carcinomas. So, okay,
I've read
CD31.
about for CD31, though practically, personally, not done that for, personally done, like, but I've read that CD31 is also helpful side of patterns for if for finding for the squamous cell differentiation.
That
So
is
basically, the tumor that we are looking at, according to that, we'll have to plan for the marker. If something related to salivary gland comes in, neural comes in, so the marker will again vary, sir. So which one?
correct.
Like CD31 will help us know the lymphocytes here better. Differentiate that with the tumor part.
Yeah, I think this discussion can go all through the night if we
Dr.
really
KP,
try to.
Yeah. Ma'am, I have one point for the margin. There is something called field of view. So under low power 4x, you see 5 millimeters of
Sorry?
view. There is something called field of view. Okay, you see 5 millimeter
Yes, yes, sir.
this
Okay.
one, circumference, like a perimeter or a circle that you see. Okay, if you see a margin, inked margin, and you're seeing the tumor, it means the distance between that is probably less than 5 millimeters. Okay, under low power, you're looking at if you don't have the equipments to measure it.
Yes,
Okay.
practically.
So it is a practical way saying that you're seeing the tumor at this magnification along with the margin. See, something which is less than 5 millimeters is positive margin. So that can be communicated. It's not involved, but it is less than 5 millimeters. As per literature, it is positive. You just can write if you don't have the software to measure it and all. It's a simple way
Yes.
of doing it.
The
Ultimately,
closest
we
margin
do
should
the same.
always be noted down in words at least. I would say
Yeah.
that closest margin at least in words, okay, that this was the closest margin observed. So it was found microscopically positive, negative, or howsoever.
Because it's a pressure
So
from surgeon
descriptions
also
are
at
important.
times. It's a pressure from surgeon also at times because they take photographs and they say, ma'am, we have excised with so much of tissue clearance and now you're saying it's involved. So it's always the safe thing is writing closest because they give this,
There are
shrinkage and
no
all that.
emotions involved in this.
Yeah,
If it is
Remember,
positive, it is positive. It is
yeah,
there.
yeah,
We
it,
have
yeah,
to
it is
give.
what
yeah,
it is.
Yeah,
yeah,
but
yeah.
And
so if it is
ma'am,
positive, we have
here
to give.
Anita Borges ma'am says wants and needs of the surgeon.
Yeah,
So he wants safe margins, but it is not there. It is need of the patient that
correct.
we have to report. So that is important.
Yeah. So as Nidhi ma'am said and you said, na sir, the closest margin is always to be mentioned. That practice I always try to like follow all the time. Yeah, so it was a wonderful and productive discussion too. And I feel as I write, I said before that this can go all the day and night long. And thank you again, Nidhi ma'am. This is
Thank you so much
Yeah.
for
Thank you so
giving the
much, ma'am.
opportunity. I hope it will be helping, especially the beginners, the postgraduates, or any of the faculties also who are starting with this. I just tried to make an attempt. Hopefully, it will be helpful.
Yeah. Thank you so much, ma'am, for giving your time and sharing your valuable inputs for such a wonderful topic, which is the need of hour for being as oral histopathologists who
we will come
aspires
with
to
I
be.
feel,
the
sir,
second
this is
part.
a way to enter in the cancer hospitals. If
Yes,
you
yes,
know
yes.
this, you can, straight away, go and, like
And it
whatever
should also
learning is
become
remaining, you
part
can
of
do
our
it there.
curriculum also.
Ah,
I feel so that it should be in detail the part of that. So, anyways, slowly the change is coming.
Yeah,
Well,
we will come with the part two, ma'am,
yes,
discussing the
part, I
potholes,
know. That's
yeah,
pitfalls.
a good topic,
Yes.
actually.
yes. Okay, okay. Thank you so much, everyone, for attending today's POPMA Study Club, and we'll catch up soon in April. Along another two study clubs will be there, so stay tuned and thank you so much. We have our upcoming national conference of POPMA, that is first national conference of POPMA at Saharanpur. During 4th and 5th of October 2025. So those who are interested, they can register for the same. And thank you so much. Thank you so much, ma'am.
Thank you, sir. Thank you
For
so much.
okay. Bye, everyone.
Bye.